we move on to the last session. Incidentally, keeping the upcoming proceedings in place, the scientific committee has decided to have the 3 guest lectures which are coming up all rolled into one. We'll go ahead with these short 12-minute guest lectures back to back, and then we'll have the last 5 to 6 minutes for the discussion. We'd like to thank this leg of the chairpersons, and our last leg of chairpersons are Dr. A.K. Umar, Dr. Hala L. Marsafabi, I beg your pardon, and Professor Muralidhar Rao. I would also request all the guest lecturers to kindly come onto the dais. Drs. Chetan Shah, Professor A.A.S. Majumdar from Bangladesh, and Dr. Shamitra Kumar. We'll set the ball rolling with the first guest lecture on ventricular tachycardia storm management 2012. Dr. Shah, please.
Thank you very much. Thanks, Dr. Chopra, and thanks, Dr. Navinandai. He's around. Yeah, he's always very inspiring, and it's a pleasure to talk in front of him. And I was praying that he's there for my lecture. He's there for most of my lectures at the CSI meeting, and I'm really thankful to him. He's there for all our KM cardio get-togethers, and we have a very good time together. Let me start with the case. I'm going to be talking on VT storm. How do we manage at this time? And let me start with the case. This is a 60-year-old gentleman who presents with rest angina. He has had inferior wall infarction 1 month ago. He has ejection fraction of about 40%. And this is an ECG on admission. What we see here is an old inferior wall MI. We do a coronary angiography. It reveals a long lesion in the right coronary artery. We have done a PTCA with stenting with 2 medicated stent of the RCA. And what happens 2 days post PTCA, he has this. He has this monomorphic ventricular tachycardia, which is degenerating into polymorphic VT and needing DC shocks, and it was about 3 episodes per day, and he kept on getting these episodes, kept on getting repeated DC shocks. So now what is the definition of an electrical storm or a VT storm? Electrical storm is a life-threatening syndrome that involves recurrent episodes of ventricular arrhythmias. It is defined as more than or equal to 3 sustained episodes of ventricular tachycardia, ventricular fibrillation, or appropriate ICD shocks during a 24-hour period. Sustained ventricular tachycardia lasts for more than 30 seconds, involves hemodynamic compromise, or requires intervention to terminate the episode. Now, what is the incidence of this VT storm or an electrical storm? It happens in, see, the data is mostly from the ICD patients, so it happens in about 10 to 20% of the ICD patients. The incidence of electrical storm is lower when the ICDs are put in patients for primary prevention versus secondary prevention. Primary prevention, we have MADIT-2 trial, and from about more than 700 patients, only 4% develop an electrical storm over an average period of about 21 months, as against a trial of secondary prevention, which was an AVID trial. 20% of the patients who received ICD for secondary prevention experienced an electrical storm during a 31-month period. Now, intracardiac ECGs that were recorded during those episodes showed that most cases were due to VT, and that they occurred at an average of 9.2 months after an ICD implantation. Now, this is a busy slide. There are lots of studies describes upon an incidence of an electrical storm, and it varies from 4 to 60%. Now, what are the triggers for the VT storm or an electrical storm? Now, we have lots of studies, and Kredner showed that presence of hypokalemia, acute coronary syndrome, or a worsening heart failure as a potential trigger in about 26% of the patients. There was a Shell trial which identified a storm in about 13% of patients. Worsening heart failure was in 9%, and electrolyte imbalance in 4%. Now, there is a very important factor in this VT storm which is known as psychological stress. It seems to be a trigger in about 10% of the causes detected by Green and 4% reported by Banch. Now, all these findings seems to be determined by an adrenergic activation, the impact of which on the genesis of storm is corroborated by the finding that an increased incidence during a daytime hours. Now the BT storm increased incidence in daytime hours, a marked effect of beta blocker therapy and a reduced sensitivity to baroreceptor reflexes. Now what are the risk factors for this VT storm or an electrical storm? Now severely depressed ventricular function or a compromised ventricular function is the most important trigger or a risk factor for an electrical storm. There is chronic renal insufficiency and ventricular tachycardia as the onset of arrhythmia. All seem to correlate significantly with development of storm. Now in MADIT2 study, patients with acute coronary syndrome and episodes of ventricular tachycardia and ventricular fibrillation after enrollment showed a higher incidence of an electrical storm. What are the prognostic implications? These patients have very poor outcome. Electrical storm might be an independent risk factor for cardiac death. In AVID trial, patients who had an electrical storm had an increased incidence of cardiac death. In MADIT2 sub-study also, patients with electrical storm had 7.4-fold higher risk of death than patients without an electrical storm. So it's extremely important. Both studies showed that the risk of death was highest within the first 3 months after the storm. The prognosis remained poor. For the patients who survived the initial period of electrical instability, many sustained recurrent electrical storms and refractory heart failure. Now what about the management? Management of this electrical storm or a VT storm. Now most important thing is to identify the causative factor of the electrical storm. The most important thing is acute ischemia. If acute ischemia, revascularization, worsening heart failure, treat the heart failure. Hypokalemia, hypomagnesemia, treat the cause, electrolyte imbalance. If the patient is on antiarrhythmic therapy, then it may result in proarrhythmias. So, withdraw this antiarrhythmic therapy. Hypothyroidism, treat hypothyroidism, and an infection or a fever. So, these are the important causative factors which needs to be attended. Most important thing is relieve anxiety. Patients often have severe anxiety and increased catecholamine levels which can amplify the severity and perpetuate the electrical storm. What about pharmacologic therapy? Amiodarone is the most important drug in the treatment of electrical storm. It has less negative inotropic effect and it's relatively safe in patients who have depressed systolic function. The incidence of TOSAT is low in such patients despite the potential for significant prolongation of QT interval. Amiodarone has resolved electrical storm at cardioversion rates in approximately 60% of patients. When compared with placebo in the ARREST trial, amiodarone improved survival to hospital admission rates in patients who had an electrical storm that involved VF or pulseless VD. Amiodarone can be more effective than other agents. Now, Levine and colleagues examined 273 hospitalized patients with an electrical storm that was refractory to lidocaine, procainamide and beryllium therapy. When amiodarone was given, 46% of the patients survived for 24 hours without another episode of VT and another 12% responded after taking amiodarone plus another agent. So, amiodarone is an important agent. It is also effective as an adjunctive therapy to prevent recurrent ICD shocks. So many of our implantable cardiovascular defibrillator patients are also on amiodarone. Now, our particular patient had prolonged QT interval and he kept on getting more than 3 episodes a day. So we stopped amiodarone. We move on to beta blockers. Now beta blockers play an extremely important role in the management of electrical storm. Now we talk about very fancy beta blockers, metoprolol, nebivolol, carvedilol, but here the most important beta blocker is propranolol. Propranolol is the most less talked about beta blocker, but propranolol consistently decreases the incidence of fatal VF during acute myocardial infarction and sudden death after myocardial infarction. Although several beta blocker decreases susceptibility to VF, most studies have focused on propranolol. In patients with congestive heart failure, propranolol decreases sympathetic outflow more than metoprolol, perhaps because beta-2 receptors prevail in failing heart. The lipophilic nature of propranolol enables active penetration of the central nervous system and the blockade of central and prejunctional receptors in addition to peripheral beta receptors. Propranolol may effectively suppress an electrical storm even when the metoprolol has failed. Now there were lots of studies. This was a study by Nadamini, and which showed that beta blockers were very important. They compared propranolol, esmolol and left stellate ganglion blockade to combine lignocaine, procainamide and bretylium therapy, and found that this beta blockade or sympathetic blockade was very important in the treatment of electrical storm. Beta blockers are known to make the animals less susceptible to fibrillation. They increase the fibrillation threshold, and out of which propranolol was very important. Class 1 antiarrhythmic agents like lignocaine, very important only in ischemic setup. In non-ischemic setup, lignocaine is not that effective, and most trials say that amiodarone is much better than lignocaine, and ACCHA says class 2B recommendation for IV lignocaine only in the treatment of polymorphic VT that is associated with ischemia. So 2B indication for lignocaine. Anesthetic agents, very important to keep the patient quiet. Physical and emotional stress that patient experience in association with an electrical storm and multiple electrical cardioversion after often perpetuate arrhythmias. All these patients should be sedated. Short-acting anesthetics like propofol, benzodiazepines or some general anesthetics can be considered in this particular group of patients. What we did in our particular patients, after stopping amiodarone, patient was maintained on sedation, beta blockers and lignocaine to control the storm. Non-pharmacologic therapy, left stellate ganglion blockade is extremely important, and it can be done under USG guidance. This was one particular report where they did without USG guidance, just using an anatomical landmarks. Insertion of a temporary pacemaker and anti-tachycardia pacing in our particular patients was associated with increased episodes. Transcatheter radiofrequency ablation is extremely important, and there are lots of studies, including Dr. Shah's study, which says that it should be considered, especially in our setup where ICD is extremely expensive, and the percentage of success is from about 60% to 100% in controlling the electrical storm. Implantable cardioverter defibrillator, when do we put in? We need to wait for about 2 weeks of VT-free or VF-free interval in this particular group of patients. So this is a protocol by which we go in monomorphic VT. We are talking about monomorphic VT. We give amiodarone, beta blockers, sedation, general anesthesia and VT ablation. So, and one more thing, one last thing is that cardiac resynchronization therapy. Now, there were studies which evaluated that cardiac resynchronization therapy, the patients who were only on ICDs and the patients who were on cardiac resynchronization therapy, there was a huge difference in the patients who got VT storm or electrical storm on the patients who were on cardiac resynchronization therapy. I really thank you very much for quite listening to my lecture. Thank you.
Thank you very much, Dr. Shah. We'll postpone the questions till the end of the session. So we'll happily invite Dr. Abdullah Majumdar from Bangladesh for his talk, Extracorporeal Shockwave Therapy. Is it a useful modality?